Dr. Kielb has had her adventures also in global health. She is a Nesbit alumni in 2002. She left Northwestern Urology and is coming back to help us out here. She was awarded the Urology Care Foundation humanitarian grant, and we'll talk about her work in Rwanda. And I think when you guys, we can probably take questions for both of you guys about grants. How do you get funded? You're looking for donations. Like, how hard is it really to get a grant?
Well, good morning, everybody. Thank you so much, Ganesh and Mady, for inviting me to speak again. I was thinking, gosh, the Nesbit people are probably tired of listening to me talk. But unlike Dr. Salami, I have no problem with public speaking, so I guess that works out pretty well. I did travel a bit to get here. I actually got back to Detroit from Rwanda at about 6 p.m. last night, so feeling pretty good, though, so I still got some energy. So I'm glad I'm early on the program, because I was in the afternoon. It might be a little different. And I am very excited to be coming back to Michigan. I hope we can figure out when that will be very soon. So I'm going to talk a little bit about working towards kind of global health equity. And this is my one disclosure. So as Tim was talking about, there are international needs, and what's been estimated, there was a Lancet commission about surgery, which was published in 2015. And if you have a chance to pull the paper, it's available publicly. It's really interesting, the perspective of what global health has been doing and what the needs are. So the estimation is about 5 billion people don't have access to safe surgical care and anesthesia. And that includes 9 of 10 people in low income and low to middle income countries. And when you think about that, that's the majority of people in these countries that do not have access, and the majority of people that don't have access to surgical care. And what happens, as Tim highlighted, is that it not only affects them physically and health-wise, but it affects their ability to get out of poverty, their ability to work, their ability to feed their families. And it turns out only about 6% of all surgeries occur in low and middle income countries. And in 2010, it was estimated that about 17 million lives were lost because of preventable surgical diseases, things that could have been treated. And in perspective, when you look at worldwide, there's about 1.4 million people that at that time period were dying of AIDS, about 1.2 million from TB, and 1.2 million from malaria. So when you think about the big things like the Gates Foundation, all the foundations are doing great work. It's mainly focused on infectious disease, medical issues, and really hasn't been a huge focus on surgical care until recently. So this is the organization I work with. I am on the medical advisory board for the foundation. It was created in 2003, initially to treat genitourinary fistula. And the woman who started it actually was a teacher. She was teaching for the State Department in Niger and retiring, and there were a bunch of people that were kind of hanging around this courtyard where they were, and she was looking for her next why, or what can I do, and someone there said, well, those women over there, you see them, they have fistula, and if you want to do something in the world, fistula is really important. And so to date, over 2,500 surgeries we performed. And, I joined IWD in about 2012. They used to be in Niger, but it became too unsafe. And so we've been in Rwanda since 2012. And so our surgical team, we bring everything we need with us. We actually have storerooms at the public hospital in the capital in Kibagabaga, or the hospital is Kibagabaga. It's in Kigali, the capital. And we do 3 surgical missions a year. And this has been consistent since 2012, aside from the gap in for COVID. And I think the important thing about that is, everybody's surgery looks great post-op day 3, and then people fly away and leave. Our team does, we keep charts, we do follow-up, we report every single mission to the Ministry of Health, and try to do it in a very sustainable way and teaching. We partner with Rwandan physicians and students and residents, and it's a great collaborative effort. And we do support a local healthcare worker at the Kibagabaga Hospital to help keep everything coordinated for us. The thing about Rwanda is that this isn't really like us. This part of the mission isn't really us like creating sustainability. It's more like helping the people, right? But really what you want to do is in global health is create sustainability. We want to be able to not have to go there at some point. Unfortunately, with the genocide in Rwanda in the early 90s, a huge portion of the physicians were killed. So there are so many bright young people there, but there aren't enough teachers. And when you are doing something wrong and aren't corrected, you continue to do it wrong. So there's a huge teaching need there as well. So as I said, how are we helping Rwanda? Well, we're treating individual patients and fixing the fistulas. We're training medical students. We're training some gynecology residents. The urology residents have rotated with our team. We do online lectures and teaching. However, the ultimate goal is to try to make fistula obsolete. And so we have a C-section training program. Ultimately, we want to train Rwandan physicians to evaluate and manage fistula, but capacity building is key. And so those are the things that are lofty goals, but I'm working towards it. I'm not going to focus too much on this, but the thing about Rwanda is they have universal health care coverage. It's mutuelles. It's a French word I don't pronounce well, so I apologize for any French-speaking people. But it's universal health care. 93% of their population is enrolled and has health care. They have health care, but they don't necessarily have access to everything that they need. It's paid on kind of a sliding scale based on your income. And the thing about Rwanda is they've invested a lot in public health to the point where now things like malaria and TB are being treated and managed pretty well, and they're moving on to preventable diseases. And this fistula and actually urology are some of the focuses of the country. They've actually increased access to C-sections, even in the poorest women of the population, which is not true in many countries. So, in many countries, developing countries of the world, as we know, women are valued less. I might only be worth 2 cows. I'm not really sure. So the healthcare dollars don't necessarily get focused on women's healthcare and children's healthcare necessarily. In Rwanda, they do, and they've really increased their C-sections. The problem being there isn't great training. So now we're seeing fistula, instead of relating to obstructed labor and delivery, to now they're almost all surgical related to C-sections and hysterectomies and things like that. So these are some of the folks that I work with. There you go. So what is capacity building? What do we talk about? So it's the key to really creating a sustainable intervention, right? So we need to look at local priority. What are the local needs of the surgeons and the patients? That should take precedence, right? Resources should not destabilize existing programs. When I talked to the Rwandan urologists, and I just had meetings with them before I left, but after my slides were due, so I got to wing it a little bit, but I can do that. One of the things they said is that when the physicians come there in urology, and there's a couple groups that come, and that takes up the ORs for the local surgeons in other areas and for the local urologists. So, we're trying to help, but sometimes we're also hurting in those hospitals because there's just only so much capacity. We really want to minimize the risk of brain drain. So sending like Rwandan doctors elsewhere to train is a problem because a lot of the time they don't come back. The physicians aren't paid that well. Hopefully that'll be changing. But we really don't want to do that. We want to train them there and let them stay there. And we need to manage complications, long-term management. And definitely research is very, very important, and the Rwandan urologists are very interested in this, which anyone that wants to talk to me about it, please do. But it needs to be collaborative, and there needs to be fair authorship. And so Rwanda is very, very particular, and the things that we've published have been with Rwandan doctors and students on it. And visiting surgeons really need to stay in the same standards of clinical care and education and research that you would here. So our charity does not let anyone do anything they aren't licensed to do in the States or wherever they practice, because going to learn surgery on someone in Africa really stinks of colonialism and things that happened in the past. So we don't want that to happen. There's me operating in Rwanda with my nice cool Rwandan surgical cap. So what is this current status and opportunity, which I really want to talk to you about? So Michigan Transplant actually is in Rwanda now, working with the urologists doing living donor transplants. And actually, they were brought to Rwanda by our organization, IOWD, which is awesome. I actually was on the plane with Dr. Punch last night. He was coming back. We were on the same flight. Previously, they sent patients to India for living donors, which is very expensive. And the transplant program is now up and running. And Dr. Punch, they send someone every single month, which is probably beyond my abilities right now, but that's a lot of commitment to really training. How many urologists are in the Rwanda? Well, there's 13 consultant or attending urologists. There's 8 residents, which is increasing to 11 per year. And there has been a request from the Ministry of Health to IOWD, our organization, because we are a trusted organization who's been there for many, many years and continue to come back, to increase teaching and collaboration in urology and develop an ERPS, or as I call it, BURPS fellowship. I love the ERPS BURPS thing, and other subspecialty training in urology. So this is me speaking at the Rwandan Urological Society meeting. There are, like I said, 13 urologists, so I kind of know most of them. And I was giving them a talk, and that's me showing them the Michigan Stadium, Go Blue. So what are the additional collaborations? So I've been working with GU Impacts, which is Jeremy Meyer's charity out of Utah. They have been going to Rwanda initially through IVU Med and now their own charity, and IVU Med as well. IVU Med sends oncologists. Dr. Moses from Vanderbilt goes once a year. And GU Impacts is supposed to be going 3 times a year, though it seems like they haven't really been that consistent, and they aren't going enough. And the Rwandan urologists I've been working with for about 2 years, talking to them about how can we help, how can we build, how can we collaborate. So this is me and a few of the Rwandan doctors. I took them some Michigan swag, just so they can, get in the go blue mode. I'm gonna leave my email up for a minute. I'm just gonna talk about what our meeting was before I left, because I don't have any slides on it because I had to turn them in earlier. So their main areas of focus right now are several areas. One, there's absolutely no one treating incontinence in women in Rwanda, either from the gynae side or the urology side until recently. They just hired a urogynecologist who's Ethiopian, and she actually works at Kabagabaga. So I'm very excited. She's awesome, and we're going to collaborate. The thing she doesn't have a cystoscope. She has no idea how to do any ureteral anything. And so it's going to be a challenge, right? Think about trying to do, urogyne prolapse and everything without cystoscopy. I mean, that's a challenge. But the other big thing that they're interested in is pediatrics and female urology and cancer. And I hate to say it, I don't think Dr. Monte's here, but prostate cancer, my least favorite part of urology. No offense to you prostate cancer folks, but 250 radical prostatectomies in training and bad neck aches, I just can't. But so with the universal health coverage, what the Rwandans want, and here's what's happening now, is that the patients are presenting with, metastatic cancer, as you would expect. There's no universal screening. However, there's huge opportunities for universal screening for not only that, and there's also penile cancer is another big cancer there. And so in Rwanda, there are community health workers in every district. So there are district hospitals, community health workers that are actually responsible for a low number of people in the community, about 100 to 150, sometimes 200 people. So they're in those villages, they know these people. And so the proposal that the Rwandans presented with me, which we talked about, is to try to adopt a PSA screening program out in the villages and evaluate for penile cancer and do biopsies out in the villages. Because the people can't get into the city center, they can't come in for testing, and by the time they do, it's often too late. And most of the penile cancer ends up in amputations and lymph node metastasis and death. So that is a proposal. We're working on it. I mean, I've met with them and talking about them. I would love to collaborate with any of you prostate cancer folks who would like to get involved. They're very interested in research. They need help. They don't know how to do it. They really, really, really want to do that, and they want our help with that as well. There are lots of other things that, they have these huge plans for urology center and all that stuff, so we just need to get a billionaire donor and just make it happen. I mean, how hard is that, right? But it's a very exciting time, and because when I first started going into Rwanda, there was 2 urologists. So how can we build anything with 2 urologists? The residency program's expanding. They can expand their positions. They really want subspecialty training. So a sustainable program of teaching, not only online, but in person about once a month with maybe a subspecialist from urology. It doesn't have to be all U of M people or current U of M workers, physicians, so that we can teach about every 2 weeks, every month, or at least every other month, to have a sustainable curriculum to really have some impact. Because I sat in on their educational meeting, and I can tell you there's lots of things we can contribute really at the basic level as far as just research, understanding, and training. So I don't know if I'm over and I have no idea, but I will stop talking. And I just want to say thank you so much. And as many of you know, I'm very happy to be here in many aspects of my life. So thank you all very, very much for inviting me. And I look forward to talking to Tim. It's going to be great.